dawn of a new era. 21st century rabies prophylaxis from India. Rabies is caused by a bullet-shaped RNA virus that is present in the saliva of rabid animals. In India, rabies is mostly transmitted by dogs, sometimes by cats, and occasionally by wild animals like jackals, mongoose, and others. The virus is transmitted to man following bite, scratch, and lick of a rabid animal. Then the virus multiplies locally, enters and travels inside a nerve, and reaches the spinal cord and brain. Here it replicates very fast, affecting its functioning that results in manifestations of classical signs of the disease. Hydrophobia, fear of water. Aerophobia, fear of air. And photophobia, fear of light. Following a rabid animal bite, it usually takes about 3 weeks to 3 months for the symptoms to appear. That is the incubation period. But this could be as short as 3 to 4 days to as long as up to 2 years. Once the symptoms of rabies appear, the patient survives for about 3 to 7 days and the disease is almost always fatal. Till date, all efforts to find a cure for rabies has failed. Hence, the prophylaxis following a rabid animal bite is life-saving and should be provided immediately and correctly. Categories of rabies exposures. Touching and feeding of animals and mere physical contact with a suspect rabid animal is a no-risk exposure or WHO Category 1 exposure. If it is a mere scratch without any ooze of blood, but with only a mark, then it is a moderate exposure or WHO Category 2 exposure. Any wound or a scratch that has breached the skin resulting in oozing of blood is a severe exposure or WHO Category 3 exposure. In clinical practice, most of the cases belong to the Category 3 or severe exposures and a few belong to moderate exposures or Category 2. Very small numbers belong to Category 1 or no-risk exposures. Modern rabies post-exposure prophylaxis or PEP. It consists of removing the rabies virus from the wounds by thoroughly washing all wounds with soap and water. Neutralizing the virus by applying antiseptics like Dettol, Savalon or Povidone iodine to all wounds. But in severely exposed individuals or those having Category 3 exposure, Rabies Monoclonal Antibodies, human, Rmab must be injected into all wounds soon after an exposure to immediately neutralize the rabies virus locally. This shall be followed by a course of rabies vaccination that induces anti-rabies antibodies in the individual about 10 to 14 days later, and it lasts for about 6 months to few years in many individuals. Guide to treating different categories of exposures. Category 1 or no-risk exposure require only counseling by the doctor and no vaccination is needed. Category 2 or moderate risk exposures require a full course of vaccination. That is 5 doses by intramuscular route on days 0, 3, 7, 14 and 28. The day of the first dose of vaccination is called day 0 and may not be the day of bite in many instances. In government hospitals, as a cost-saving measure, the vaccination is given by intradermal route and the dosage is 0.1 ml of vaccine given in 2 sites in the deltoid region and on days 0, 3, 7 and 28. In category 3 or severe risk exposures, only vaccine would not suffice, and hence, in addition to vaccine, use of Rmab is life-saving. Novel Rabies Monoclonal Antibodies, or popularly known as Rmab, or by the brand name RABISHIELD. In line with Make in India initiative of Government of India, the Serum Institute of India has come out with a novel anti-rabies antibody that is free of both animal and human serum or blood derivatives. It is produced in the world for the first time from India. It offers safe, pure and efficacious passive immunization against the dreadful rabies and is life-saving. Its dosage is 3.33 IU per kg body weight, and the calculated dosage is injected by infiltration into and around all wounds as anatomically feasible, and any leftover quantity is injected at a site away from the site of vaccination, that is, usually in the hip region. If the calculated dose or volume of Rmab is insufficient to infiltrate all wounds, then it is diluted with a sterile normal saline to a volume that is sufficient to infiltrate all wounds. The Rmab replaces the currently used both equine and human rabies immunoglobulins. Now let us study a case. Rani is playing with a dog in front of her house. She suddenly gets bitten by it. Her mother takes Rani to anti-rabies clinic. Her history of dog bite is taken. She is given wound wash with soap and water. Povidone iodine is applied on all wounds. If povidone iodine is not available, alternatively, Dettol or Savalon may be used. As wounds are bleeding, it is category 3 exposure. Hence, it is injected with Rmab. A vial of Rmab consists of 100 IU in 2.5 ml, that is, at the rate of 40 IU per ml. The dosage is 3.33 IU per kg body weight. That means a vial of 2.5 ml would suffice for a patient of 30 kgs. The Rmab is taken out from the refrigerator and brought to room temperature. The calculated dose according to the body weight of Rani is injected into all the wounds. And the leftover is injected intramuscularly at the site away from the site of vaccination. A full course of IM vaccination is given on days 0, 3, 7, 14 and 28 into alternate deltoids. She is advised about compliance to vaccination, report adverse events to anti-rabies treatment if any, to look for the bitten dog and reports its condition if it is practical, and about no dietary restrictions. Now, Rani is cheerful and goes to school as usual. In summary, the rabies PEP or anti-rabies treatment comprises of three components. 1. Wound management, consisting of washing of all wounds with soap and water and applying an antiseptic. 2. Full course of rabies vaccination, 5 doses by intramuscular route given on days 0, 3, 7, 14 and 28, or 4 doses by intradermal route given into the skin in the deltoid region on days 0, 3, 7 and 28. 3. In case of severe or WHO Category 3 exposures, in addition to a course of vaccine, administration of Rmab. By infiltrating all wounds, and if any leftover is injected at a site away from the site of vaccination. Now, let us know the opinions of the experts. Is there any risk of medico-legal issue if Rmab is not recommended or prescribed?
Rmab and RIGs are life-saving in category 3 exposures. Not administering or not prescribing them amounts to deficiency in medical service. If the doctor is sued under Consumer Protection Act, he or she is liable to pay compensation under the Act.
How does RABISHIELD prove to be life-saving in category 3 or severe rabies exposure?
The rabies vaccines takes about 2 weeks to produce protective antibody titers of 0.5 IU per ml. The Rmab, when injected locally in severe category 3 exposures, will neutralize the virus at the site of bite and it will be life-saving.
How is Rmab superior to E-Rig and H-Rig? Is there any data on its use worldwide?
Rmab is monoclonal, unlike ERIG and HRIG, which are polyclonal. Rmab is a highly purified product which requires in small quantities and does not require a skin sensitivity test, unlike ERIG. There is sufficient published data to support this.
Should there be any time gap between Rmab and vaccine administration?
Rabies immunoglobulin or Rmab, whichever is used, should be used as soon as possible. But however, there could be some situations where Rmab or RIG may not be available, or the patient may not be able to afford it on the day 0, or maybe during referral of a case where from the site of vaccination for RIG administration. In these cases, RIG should be given, but it should not be given beyond day 7 of active immunization, because by that what will happen, there will be immunointerference, and administration of RIG beyond day 7 of active immunization may lead to decrease in the antibody production due to active immunization by vaccination.
What should be done with any leftover Rmab after infiltration of all wounds?
The calculated dose of Rmab or rabies immunoglobulin should be infiltrated in and around the wound as much as anatomically feasible. But however, in some cases there may be some leftover of the calculated dose of Rmab or rabies immunoglobulin. In this situation, the leftover part of Rmab or rabies immunoglobulin should be given intramuscularly, but at a site away from the site of administration of the vaccine.
What if the amount of Rmab dose calculated as per the body weight is insufficient to infiltrate all wounds?
Rabies immunoglobulin or Rmab be diluted with normal saline only to cover all the wounds.
Should vaccination be delayed if Rmab is not available?
No, on the contrary, vaccination should be started as early as possible, and you should make sure that the patient is taken to the nearest center where RIGs can be administered.
Should vaccination be restricted to 3 doses if the animal is healthy 10 days after the bite?
If an exposed person has been started on vaccine and has been administered 3 doses on day 0, day 3 and day 7, and if the animal to which he or she is exposed is a dog or a cat is alive on day 14, actually the treatment can stop, the vaccination can stop, but it is advisable to skip the dose on day 14 but administer the dose on day 28 so that the modified pre-exposure benefit is given, and a subsequent exposure the person can be given only 2 doses of vaccine and the need for rabies immunoglobulin or Rmab is not there.
What should be the treatment in case of licks from suspected rabid animals?
Licks by a rabid dog on a broken skin comes under category 3 exposure. Hence the management is very clear. Wound wash of that particular area followed by rabies immunoglobulin administration or newly launched rabies monoclonal antibody, that is Rmab, and followed by further with full course of vaccination as scheduled.
What should be done if the bite is from a healthy looking vaccinated pet dog?
As rabies is endemic in this country, we advise that even though the dog is vaccinated or healthy looking, a complete course of post-exposure prophylaxis should be given. If on day 10 of observation the dog is alive and healthy, the schedule can be stopped.
What should be done if a patient misses a dose of vaccination?
If a patient misses a dose of vaccination, we should not be very much alarmed. If the delay is of 1 or 2 days, it may be plus or minus 1 or 2 days. Patient starts the vaccine on day 0, and on day 3 if the patient comes 1 day late or 1 day early, it does not matter. But day 7 we should ask the patient to come on schedule. But similarly with day 7, but for day 14 and day 28 the gap is allowable is slightly larger, it is 2 or 3 days. But we should always insist the patients to come on schedule because they are taking a vaccine which is life-saving. They should not play with their lives.
If a patient comes to clinic 3-4 days after the bite, is Rmab of any use in such cases? Should we still ask the patient to wash wounds?
If the patient reports late to the treating physician, still the bite wounds must be washed with soap and water and antiseptic lotion applied. The vaccine and rabies immunoglobulin or Rmab should be administered.
What is the recommendation if a victim has been fully vaccinated with 5 doses if again bitten by another dog within 2 to 6 months?
2 doses of the rabies vaccine need to be administered on day 0 and day 3. There is no need to infiltrate locally RIGS or Rmab.
What is the advantage of pre-exposure vaccination, PrEP? Who benefits most from PrEP?
Pre-exposure vaccination primes the immune system of the individual, and following a rabies exposure, only 2 doses of rabies vaccine are required in such individuals. The first dose is given on day 0 and the second dose on day 3. This elicits a good anamnestic response in such individuals. There is no need of giving rabies immunoglobulins in such individuals. The groups of people or individuals who require pre-exposure prophylaxis include veterinarians, laboratory personnel working in labs and handling rabies virus, dog and animal catchers, including municipal dog squad members, people going for a regular walk or joggers, postal and courier salespersons, forest and zoo staff, children and other persons who may be exposed to dogs or cats due to their vocation.
What should be done if a PrEP vaccinated child is bitten by a dog?
If a pre-exposure vaccinated child is bitten by a dog, First is the wound toilet should be as usual, washing the wound thoroughly with soap and water, application of povidone iodine, but this child does not require any passive immunization. The child does not require equine rabies immunoglobulin, human rabies immunoglobulin or Rmabs. All that the child will require is 2 shots of tissue culture vaccine, one on day 0 and another on day 3.
This most modern rabies prophylaxis with the new Rmab and the new rabies vaccine is safe, efficacious and life-saving. This video is produced in the public interest by Serum Institute of India Private Limited, Pune, India's #1 biotech company and the world's largest vaccine producer, manufacturers of Rabies Shield and Rabies Vaccine.